So my name is Paula Oliveira. I'm the Global Head of Strategic Services at Brain Finance, and I'm going to facilitate our conversation on the role of AMCs in the economics of modern healthcare. So I'm joined here by leaders from different parts of the health care industry. So we have Elizabeth Hampson, Health Innovation and Life Science Partner at Deloitte. We have Dr. Markus Renner, Chairman of the International Brand and Reputation Community. Roger Scarlett-Smith, Independent Advisor, former President of GSK North America and EMEA, and EVP at STADA Group. And we have Sam Milliken-Smith, founder of Heba, which was acquired by Joy Parenting Club. So thank you again for your presence, for being here. I'd like to start with a question for all of you. So we heard in the panels and in the conversations here, academic medical centers sit at this intersection of healthcare, research, and education. So from your experience from different parts of the industry, and working with those organizations as well, what role do AMCs play in the modern healthcare system, and what is the potential to create more value? Maybe we can start with you, Elizabeth.
Yeah, very happy to start. Thank you. I mean, you talked about the clinical role, obviously very important, and then the educational role, but then the research role, as talked about by Hugh Montgomery earlier, so important. And one of the things that struck me in the opening speech was about how secondary care in hospitals are about 40% of the expenditure, I thought it was, in the US. In the UK, it's about 50%. And we know that we're not going to have a sustainable healthcare system unless we look at more prevention. Diabetes, I think, is a great example, and obesity. So it's about understanding what are the needs of different healthcare populations and what are some of those challenges, both within the hospital setting, but how do we keep people out of hospital, and how do we research that to understand really what can create more sustainable outcomes in terms of finances, also as a productive organisation and a nation, making sure that we're keeping our population well enough to keep our economies strong as well. So I think they have such an important role, but then there's also that role about actually attracting life science investment to the region and to the country as well. So I think they've got so many different roles that are outside of that piece, and I think that's why the brand of the academic medical centres is so important.
Thank you. And Dr. Markus, you have a thesis around reputation and of those organizations. So from your perspective, what is the role of academic medical centers and how to create more value?
Maybe on a general level, I would say this is a broader level for hospitals. Say the whole ecosystem is to provide to the core of the core, and that is curing. Yeah, that is what we all should focus on in the system. And if I look at for example, it's a German, it's a Swiss system where I've been brought up, where I live. Although we have to reduce costs, we have to be more efficient, and that is something we should always think about. It means how to improve in the end the outcome, which is the curing of the patient. But what I see, for example, in Germany, there's a stretch between we have the highest costs in the system, the healthcare system in Europe, but the average life is less, so it's just medium in Germany. So there is a mismatch between the investment and the outcome. So that is something. So looking especially at medical health centers and academics, I would say one important looking at from the pharma side, because I've been working in the pharma industry for 15 years or so, is to provide the patient groups for the trials, so in quality and in quantity, in high quality and with a high speed, making the contracts available. That is very knowing what pharmaceuticals invest in these trials, and how cost intensive that is, and giving messages to the analysts and to the investors. So that is a key topic. Then second point would be data integrity, having the proper data, making it all audit proof,
giving to the regulators. That I would say these are the most important factors.
Okay, thank you. Maybe if you continue from a pharma perspective.
Yes, yeah. Well, my background is really in consumer healthcare. So while many of the people in this room have got many thousands of patients, I've had many billions of customers. So the scale of the impact of what we do is really significant, albeit at a less personalised level. So when you're running a consumer healthcare organisation like I did, the largest one in the world actually, you really have to have two things in mind. One is consumer experience, so consumer preference. The other one is expert recommendation. That's the essence of consumer healthcare: consumer preference and expert recommendation. So understanding the channels by which expert recommendation can reach consumers is really critical, and it starts with the very top of the tree. You need to understand what the basic science is saying and what the best experts have got in mind when they are considering the therapeutic categories that you're operating in. Then you take that and you bridge that to consumers one way or another. It could be through recommendations at the pharmacy level, or it could be through advertising, or it could be through general reputation. But as a result of this approach, I've had multiple associations with AMCs over the years, and have had the privilege of interacting with the really eminent scientists, leaders in their field. And the reason they're prepared to talk to me, unqualified and capitalist, kind of non-ethical, you could call us all sorts of things. The reason they're prepared to talk to me is because that's their way they can scale their impact. They can influence treatment protocols that can affect billions of people. That for them is really interesting. If you're interested in your role as delivering the best medical care, then there's every reason to believe that you should be interested in scaling up that impact and addressing a much wider population on a global scale. So that's kind of where I'm coming from. It's a very different end of the telescope from what we've been hearing about with hospital treatments and academic research, although we did a fair amount of that. We did many clinical studies. This is more about how you can translate that into a real impact at the consumer level.
Mm-hmm. No, thank you so much. And from a startup perspective, you worked in VC before, you came from different cross-sector experience. From your perspective, what is the role and what are some of the opportunities to create more value?
I think the point I would want to emphasize is the importance of the role that AMCs have in building trust between new innovation and the general public. I think healthcare as an industry is pretty unique in the need to build trust with your patients, your consumers, your customers, however you want to phrase them. And for context, Heba, an organisation that built healthcare software for children with long-term conditions targeted at their parents and their care support workers. We were recently acquired by a US parenting organisation, hence the point around Joy Parenting Club. But as we were building and scaling Heba Care, we really had to build trust with families who were supporting children with a range of developmental disabilities or long-term conditions like type 1 diabetes. How can you do that when you don't have a brand name like GSK, but you're a startup and there might only be a couple of people behind the website that families come across? Well, we were very fortunate that there are programs that exist funded by the likes of the National Institute for Healthcare Research, Innovate UK, Bupa, a number of NHS organisations. The NHS runs a series of NHS innovation accelerators that we were fortunate to get onto and receive funding. And there are many, many more in that space as well. I know Gosh does a great job. There's a number of leading children's hospitals in the US that facilitate these sorts of programs. And what it allows for us to do and for innovators to try and do is actually build something, have that funded, have it supported, have it endorsed, and then get it in the hands of families who can benefit and who trust the platform, and ultimately get the evidence that shows that it helps or it doesn't help, and then move on to the next stage, which hopefully can become a bit of a flywheel effect, because once you've got one logo on your kind of endorsement slide, you've then got a lot more goodwill to be heard by others, whether it's customers or funders and so on. So I think it's about building trust and acting as a bridge that's quite unique in healthcare.
Thank you. So, Dr. Markus, what are some of the challenges in building a strong reputation? And maybe I'll go to you, because as you mentioned now, there's a difference being a big organization with already an established name versus being a startup starting this space. Okay,
so maybe I'd like to put it in a little broader perspective, because I had the pleasure to do a PhD on that topic. The most mentioned words here so far on the whole day were trust, and the last contribution was on risk. So I'm happy to hear that. And just a little aside on those topics and how they intervene with reputation and especially with the reputation of AMC. We have to understand that we live in a trust industry here. This is a trust sector. And it is not only one trust sector that is the most important. Let me put it that way. It's the sector where trust is most important of all industry sectors. And I'll tell you why. And that is based not on my works. It's general knowledge in economics, and I studied in business psychology. So you have three sectors or three dimensions. One is the so-called search goods. You might have heard that. Search goods are like, you buy a jeans, and if you buy the jeans, you can test it. And even before buying it, you know on the quality you're aware, and then you wear it, and then you recommend it or not. So that is an easy one. This is where trust doesn't play a role. There's no risk, almost no risk. Yeah. Second one are the so-called experience goods. That is, for example, you have a meal or a haircut. Yeah. Then you cannot experience the meal before you had it, but while having it, or in the worst case, next day, you have problems, stomach problems. Yeah. Then you will never go into that restaurant again. So let's say risk plays a role, but not that important. And in the pharmaceutical industry, or let's say in the healthcare industry, it's called trust industry, because trust is everything there. Yeah, because of two reasons. One reason is you have an extreme information asymmetry, because the knowledge on it, even for the doctor who recommends or who prescribes a medicine or a pill, he cannot really guarantee what's in it. Yeah, and so there are many people, or let's say the patient has most of times not the knowledge, not even when reading and diving into it, he cannot know. This person cannot, the patient is not able. So he has to trust to intermediaries like the doctors, or the hospitals. And the second factor is the stakes, the high stakes. It's life. Mm-hmm. So if you have these two factors together, that makes it why it's called the trust industry. Okay. Yeah. And in this case, last word on that is the intermediaries, or the reputation and trust is like a proxy for knowledge and trust. Mm-hmm. And that is why it's everything in here in the industry.
So in your experience, when you were partnering and collaborating with some of those AMCs, what are the things that you looked for? What made you trust one organization more than another? We heard from Hugo's presentation that advanced care is the most important one in reputation, but what are some of the
I'll give you an example. When many years ago I ran the analgesics business globally for GSK, which it's a very widely used category. So many, the amount of the penetration on a global level of analgesics, even just the GSK analgesics, was significant. So we approached people from Johns Hopkins, from the key institute in India, local organisations in the UK and Germany. In those days, we didn't have the imagination to really think about going beyond those kind of territories. We didn't, for example, have any Chinese or Middle Eastern. We did have one Middle Eastern representative, to be fair. But we assembled a panel of about 20 advisors who we knew had published in the area, who were often not directly related to analgesics, but more specific, like kidney specialists. So they knew the impact of chronic medication on organs, and liver specialists, for example, people who are published in the area of treating overdose, which is a critical issue. So we selected people who we knew were global opinion leaders in the area, and I honestly didn't expect us to be able to attract that much interest for supermarket pills. But as I say, that couldn't have been further from the truth. We ended up with really, we were very careful. we had to act in an incredibly trustworthy manner in approaching these people. Obviously, GSK has a reputation which some startup companies now need to create, but we had an existing reputation which allowed us to approach people from a basis of this is a trustworthy organisation. I think, you know, that was a very key advantage, but it just shows the benefit actually of having a very strong, trusted brand to work with, and we were able to attract really top talented people who'd, you know, kind of collaborated with Nobel laureates, that kind of level of people who were nevertheless interested in providing guidance to, you know, for in the area of self-medication. So that was quite a surprise. But I think on reflection, the organisations that we approached were also the most ready to collaborate because they were seeking to multiply their impact and influence well beyond their patient treatment remit, or even their academic remit. And I was interested to hear about the Saudi Arabian hospital group that's looking to have regional impact. Well, I would say, forget regional, go global. The science is global, right? You know, and the people like Johns Hopkins and so on were keen to have global impact.
So that openness is very important, isn't it?
Yeah.
So that links directly to you, I guess, because what are some of the challenges being a startup that is not established? You mentioned some of the partnerships that you had. What were some of the challenges and barriers that you needed to face to attract those collaborations?
I think getting a foot in the door in the first instance, because there was a question, how do you choose your AMC? I think certainly in the early days of building a business, like you'll take what you can get. Anyone who's giving you an olive branch, you'll jump at the opportunity for. And there are some great programs out there that are designed explicitly for that. We were lucky that they existed. They gave us a foot in the door. But I think as soon as you have that foot in the door, you've got to work really hard to stay relevant, to stay top of mind. And then you can be slightly more discerning about how you would pick an AMC to work with. A lot of those olive branches that you're offered, to be honest, and this isn't problematic, but they are just marketing exercises for these healthcare organisations to demonstrate that they have an awareness of technology and AI, and they can point to that in investor presentations. That's fine because it benefits the startups, but it might mean that when you've got your foot in the door, actually there is no clinical champion with capacity, or there is no route to actually using your technology on the patient population in order to run a study that might demonstrate it can be effective. So I think once you've kind of done the work, if you're able to get a foot in the door, you can then choose and say, okay, well, there is capacity here, there's a genuinely willing kind of clinical champion who wants to take a punt on seeing if this can support the people he works with. Or it might be the case that you're actually just working with a marketing team and that still helps you because you can then put on your fundraising deck, we've got the logo of this organisation here, and then that'll help build a degree of credibility that allows you to have the conversation with the next investor and kind of convince her to come on board with supporting your goals. So there are challenges in the early days, and I think if you work hard and you earn a little bit of credibility, a little bit of trust, you can become more discerning, but it's very much about trying to take what you can get in healthcare, which is hard because it's so capacity constrained.
Okay, thank you. I want you to go deeper into innovation. You know, you work in innovation and especially in policy as well. You know, so if we go into the point of AI and digital tools in mental health care and healthcare in general, so I think we heard in the previous presentations about screening, personalized guidance, scalable access, etc. So how, and of course there are some of the risks as well that we heard from bias or ethical concerns. So how are AMCs, or how should AMCs to be balancing this promise of technology with the risks, including the reputational risk of something going wrong?
Yeah, thank you. I'd like to go back a little bit to that piece about information asymmetry first, and I think there's a real shift in information availability, and one of the challenges is about the real trust and actually misinformation in that. And we were running some panels and discussions in my team around prevention in the UK recently, and almost every single organisation, from consumer healthcare organisations to charities, etc., were challenging about the fact that LLMs actually can recycle the information. You don't necessarily get the most trusted source first, and leading charities actually one of their main roles is actually providing the right information for patients. And so I think the role of AMCs in actually having that connection with patients and being a trusted brand in a world where misinformation can get spread so quickly is so important. And I think that's where technology comes in as well. Thinking about when we're using technology, are we just recreating the biases within the healthcare system today, or are we actually understanding where some of those biases come in and actually training them out? So, for example, thinking about where gender or race-based and ethnicity-based inequalities are in, and are we actually designing new pathways that just perpetuate those inequalities, or are we using the technology to actually create a more equitable healthcare system and better equality across those pathways? And I think the clinicians and the academic medical centres have such an important role in identifying some of those challenges and seeing where the outcomes differences are between different patient groups and what might be driving them in those patient populations. And I think we're on the cusp of a world where we see more challenges as well as great opportunities. And I think their role is more important than ever in understanding some of those challenges that we have around particular patient populations, and making sure that we're designing more ethical healthcare systems for the future.
Thank you. From your perspective, maybe, Roger, how to balance, these risks and opportunities of technology in AMCs, but also in the wider healthcare system?
Yeah, I mean, it is a fact that there's just a glut of information, isn't there? And, and not all of it well sourced. So, I mean, companies like the Mayo Clinic or whatever have perhaps got a really good brand on information. And I think that maybe the NHS can step up a bit on this and really play a more leading role in providing, easily accessible treatment guidelines or navigable means of self-diagnosis, etc. They need to think more about that, because if they don't own it, then somebody else will. And I think that there's a very strong basis for collaboration with responsible industry players who operate at scale in these areas to collaborate on how best to provide appropriate guide pathways towards better treatment. And you could argue that one of the key critical factors nowadays is that healthcare, modern healthcare is in the title here. Modern healthcare is self-care. Even at the hospital level, people are preempting hospital discussions through consulting. Used to be Google, now it's AI, right? So people are going armed with partial information, and that's just a dynamic that we have to really contend with. And I think it must be a bit of a nightmare for doctors now to have what you might call a semi-informed patient who kind of knows their rights and so on, arguing the toss about things. So how do you combat this kind of morass of misinformation, or perhaps sometimes well-intended misinformation, but still misinformation as it stands? And that's where I think collaboration between responsible industry and AMCs can really play a role. And I think both parts of that need to step up.
Mm-hmm. I saw some nods there. Do you like to add anything about this balance?
Especially in these times, we did a lot of research on that. Opposed to former times when we didn't have, for example, internet, or today you Google, you have something, but that is a typical process. You have something, or you think you have something, and then you Google it, and you think you're dead. Yeah, that's what happens. Yeah, and then end up in a bubble, and there could be this, that, and so that would happen. And we know from research that doctors hate that. Yeah, because the patient comes to the doctor and says, "I might have this," so I have making assumptions, and maybe sometimes they read something into that the doctor didn't have time to read, or maybe they really dive into scientific research papers or whatever, or the University of X, Y, and Z is researching that the doctor is not aware of that. That really is a problem, and makes it even more important that you have the kind of, let's say, the trusted person, which could be, for example, your one general practitioner, and who has, for example, I have one, a general practitioner, which I, wherever I lived, once a year I go to this person. That is my trusted partner, and he knows me, and I let him do, the assessment or how I feel.
Help me to digest what is
exactly.
true and what is
Yeah.
not.
What I'm saying is the trusted partner, might it be the medical doctor or a hospital, whatever, yeah, the caring person has to really focus on that.
Sam, your business used to do a good job at using technology, especially in the intersectionality of different treatments that parents with children with any health issues had. So how was it? So how did you leverage technology to provide a better care?
Yeah, and one thing I wanted to say just on the former question as well, that I think when questions come up over kind of risks and opportunities, which is obviously really common when you're building technology in healthcare, I think it's important to point out there is a risk to not adopting technology. There's a risk to staying facts-based. There's a risk to not seeing 20% more patients because you've got an AI scribe in the room with you. That doesn't mean there's a risk going in the other way, but I think the status quo is a risk in itself, and I think people sometimes don't appreciate that. I mean, take that with a pinch of salt because that's coming from the startup person here, but it's worth, I think, pointing that out. But the reason Heba Care originally got built really is because children's care is quite unique in that it's particularly fragmented. Healthcare in its own right is fragmented. If you're a child with cerebral palsy, you've probably been born at an NHS hospital somewhere, and then maybe you go to a specialist like the Evelina or Great Ormond Street, and then you go to a specialist school. You've got support from your local authority, perhaps private care that's been funded by an NHS payout, and you've got all sorts of other organisations in the mix. And Heba is a platform that allowed families to store, track and share important information and get access to trusted guidance. I think AMCs are quite unique in the world of healthcare because they, through the research they do, also become quite well integrated with the ecosystem of support around them rather than delivering a specific care pathway at a time. They have to think sometimes a bit out the box. So they were particularly embracing of the goal that we were looking for, which is can we run, and we did run studies that demonstrated the benefit to families who were not just going through a single patient pathway at a single NHS trust, but they began the patient pathway at NHS trust and then were engaging with lots of different organisations. And AMCs have a bit of weight in being able to get those ecosystem of organisations on board. If you went to a special needs school and you knew that the Evelina was endorsing the study you were running, they are much more likely to take our study seriously. And actually, the direction that we've gone in now with Heba is even more that way. So now that we're part of an international parenting organisation, we've stretched beyond just healthcare needs, but general children's support needs as well. And I think we're hoping to be able to continue the research we've done through grant-funded studies and with AMCs to demonstrate that support can have a positive impact on families generally and the professionals that support them in their life. So I think AMCs are really kind of unique in the healthcare system of having the ability to bring on board a load of different organisations across health, education and social care. And that was really helpful for us in terms of what we were building as a care coordination platform.
Mm-hmm. And especially because you are looking at the children and the families and the wider system, not just one specific need, isn't it, and how they can help.
Exactly.
Elizabeth, I'd like to go back to something you touched on gender. So globally, it's estimated that only around 5 to 6% of health research funding is dedicated specifically to women's health, despite the difference between male and female body. So, for example, cardiovascular disease, I think we heard on diabetes as well, and in the previous presentation. So, have you seen examples where overlooking sex or gender had clinical economic consequences, or also on the flip side, where you saw benefits?
Yeah, I think this is an enormous topic, and it's one that's getting a lot more publicity and awareness now. I think one of the things that we see is that we do see inequalities in diagnosis, particularly in cardiovascular and outcomes for women with cardiovascular disease, because the pathway has been designed around men, and that has led to under-diagnosis of women because they don't present in the same way that men do. So actually having gender-specific pathways for diagnosis and actually treatment is really important. And one of the things that I always come back to is that actually, if you think about it, women were only required to be included in clinical trials from 1993. Now, that was a long time ago, but that means that many of the drugs and similar that's on the market today weren't actually tested in women. And we see very large increase in adverse events for women around pharmaceutical products. There's challenges around the design of medtech products, etc. So from every single stage, right from the use of male models, right at the very early stage of research, to lower representation of women in trials, to not actually looking at the gender differences around actually feeding drip by drip by drip into the healthcare system. And I think the thing to also say is this actually has benefits for men as well. If we're looking at what a gender-specific pathway looks like for women, that also means men get more specialised care where it's needed as well. And that we have seen drugs and devices being taken off the market as well as healthcare outcomes. So I think if it's in everyone's interest, the companies, the healthcare systems and the patients, to think about this more in the way that we design research. And obviously academic medical centres have such an important role in that, thinking about what's the mix of the patients that are on clinical trials, or how they're designing, or how they're researching, or even understanding the types of challenges that need more research attention. So I think they're really a large part of the key to the solution to this. But also I think the role of industry partnership really, really important in this too, so that they work together to understand there are massive benefits for those companies investing in health innovation who get this right, because they're going to have more patients, they're going to have better outcomes. There's a big economic and business opportunity for organisations too.
How was it at GSK or STADA Group? This gender lenses.
Well, I think there was also different. We were very much a global organisation, so we had to think about what the impact was of our medicines among many different racial groups as well, and age groups. So we did have gerontologists and paediatricians in the group. So age diversity, racial diversity, and I think probably at the time, I regret to say that we didn't perhaps put enough focus on the male to female thing. There were even more important kind of differences that we were looking at, or at least we felt that they were more important. So I think that's a bit of a good rebuke, actually, that it is time we woke up to one of the most important differences in how we can approach, getting clinical evidence or understanding how best to deploy our medicines in the general population, and 50% of the general population is quite a big minority.
The majority. Dr. Markus, any view in terms of the impact for reputation or opportunities?
Just as a general remark on that topic, diversity is also something that AMCs can stand out or excel in having and offering that to the pharmaceutical companies. Yeah. It's obvious that 50% of the population is female, so it's absurd that that they are not covered proportionally in trials. And same with children.
Mm-hmm.
Yeah.
Yeah. Anything from a children's care perspective? Any lenses that you had to look into diversity on a broader sense, but also in gender?
Yeah, sure. I certainly would echo just what's been said. I think that the angles that might be interesting from Heba's perspective, I think disability, which is what we were focused on, disproportionately affects those from lower income backgrounds, from minority ethnic groups in the UK, and 90% of our users who were parents were mothers. And so we saw a lot of the need for increased attention on this. And I used to work in the venture arm of United Health Group, looking at what was being funded in healthcare technology, and certainly all of those areas that we've just talked through were getting far less funding. I think more and more it's realised that women's health hasn't had the funding that it requires. Children's health, interestingly, a lot of the brands that we spoke about earlier are children's hospitals, Great Ormond Street, and those in Australia and in the US. But children's health, when it comes to funding for innovation, is actually paediatrics is one of the least funded medical specialties compared to others, despite the fact that it has this kind of brand appeal, and Great Ormond Street is one of the biggest charities. So those are some of my 2 cents on topic.
So we have about 6 minutes left. So just as one final question to all of you. So from your perspective, what is needed to improve the ecosystem? But also if you could consider any trends or anything that is important that we didn't touch in this conversation to improve collaboration, but also to improve the economics of the system. Can I start with you?
This could go in so many different directions. I think one thing that I think is really, really important is around financing and thinking about the longer term financing of these questions, and how do we ensure that there is enough time and money dedicated to research and academic research and those questions and those partnerships. And I think industry has a role in this, but I also think government thinking about how do they make sure that we're not just trying to solve for the problem that organisations have today, and we're thinking about how do we invest over multiple years. And I'm saying this particularly because we've done a lot of work at Deloitte on prevention in recent months and the last year. And one of the real challenges is we often just invest for treatment and for actually getting the money in today, whereas to really create better health outcomes and sustainability of the healthcare system, we need to be thinking about how do we invest in what saves money over 5 or 10 or whatever years, and that's often a lower priority. And I think making sure that we're investing in answering those questions and how do we create a more sustainable healthcare system through the work that AMCs and industry partnerships are doing is going to be so important for us to have the right type of sustainable healthcare and health outcomes in the future. But yeah, we could go in all sorts of different directions. I wonder where other people are going to go with that question.
Yeah, I would suggest, or if I would start again, in the industry, I would have started earlier in more research on what are the triggers or the levers for instilling trust among the different stakeholder groups. I would start with audits internally. What are the hurdles, the obstacles, trust in the organization? The larger the organization, we all know that, and that they're blocking sometimes trust. And of course, then to the external audiences, the stakeholders, may it be patients, healthcare providers, so the insurances. Knowing or always having in mind that trust is kind of, based on what I said earlier, kind of economic heuristic. It's a rule of thumb for this lack of information that normal people have, and that is, you can say, it's the grease. Trust is the grease that makes transactions happen. Yeah. Economic transactions that otherwise would be paralyzed.
Okay. Any trends we didn't touch on, or anything that could improve the ecosystem?
I think there's an underlying theme here, which is there's one of mutual dependency. It goes beyond trust, but there's simply the objectives of any healthcare system cannot be met except through collaboration with commercial organisations and many other organisations. And similarly, the objectives of commercial organisations cannot be met except through responsible collaboration with AMCs and other healthcare professionals. So this is a requirement of the future. The only question is how can that be facilitated to be more efficient and more transparent and trusted. So it's not a question of is this a good thing or should we? You have to. We all have to. So we're all in it together. That's my conclusion.
Thank you, Sam.
Yeah, I think that was a really nice way of wrapping up probably the point I'm going to try and make and say less succinctly now, but it was about the ability for, or maybe even the obligation for an AMC to be able to support organisations through that valley of death that was talked about earlier, or decide that they shouldn't be supported and they aren't the ones to make it. But I think if there can be a view from those trusted brands that they have a responsibility to support those organisations that should be making it through the valley of death, then they can keep them supported to generate the evidence, to generate the time to invest in the technology that can bring these tools and technologies to market. We were fortunate that we're in the right place at the right time for NIHR funding or getting our foot in the door with a national insurer, for example. It was only because of that and the time and the resourcing that they had that allowed us to demonstrate that the idea we had that we could provide better support to a population with long-term conditions would be beneficial to them and the healthcare system as a whole. But if we hadn't had our foot in the door, didn't have those olive branches, it would have been an idea on a PowerPoint slide that never really saw the light of day. So I think that mutual dependency and the mindset of it being part of the function to consider whether you should bring innovations to life, I think would be the takeaway that I'd answer that question with.
No. Thank you so much for your time, and I'll hand over to David to close.